it's not about the aircrafts, it's about the systems. So you should have helipads at all the hospitals. We've gone ahead to write to most of the hospitals to get helipads. We've also, what we don't have specifically probably in the organization is to have trained aeromedevac doctors and nurses so that they can, at any point or location in the country, we can use the services that they have. I would say that we are poised, we have the posture, we have the capabilities, and we can do it when we are asked to. I don't want to talk about the financial matters. It costs a lot to do this. I mean, the helicopters, for example, cost about $6,000 an hour to do this kind of operation. So we do it. If we are requested through the referral system, we will do that. I just want to add that how do we do our medical evacuation? Generally, it comes from the north to the south, not the rivers. And some of the difficulties has been getting oxygen for the patients. The transfer of a patient from an ambulance onto the aircraft, the stretcher systems. And we've been working with the National Ambulance to have a seamless transfer of patients. And that's been some of the difficulties we have, because the kind of stretchers we have on the aircraft are not easily transferable. So we can't exchange the stretchers. Above all, this is one of the issues. I have an aircraft that can medevac about 6 critical patients. But you don't have an ambulance can pick all the 6. So if I bring one aircraft, you have to mobilize about 6 ambulances before you can pick the patients. So far, we have been able to do that, and I think that one of the recommendations that I can see where we can improve is being able to develop the medical facilities in the areas that they are needed. If you're asking me to evacuate somebody from Jirapa, he has to pass Wa Hospital, he has to pass Kumasi Hospital before he gets to Accra. Sometimes the golden hour dictates that the patient must be in the hospital within a certain time. Probably it will be my very long preliminary comments, and if there are any issues.
Yes, I think I should just ask you a quick follow-up. So do we currently have an aircraft that plays the role of an air ambulance owned by the state of Ghana?
Well, that's what I said again. We will not necessarily have to have one, but we must have a multifunctional asset. And it takes an hour for any of our aircraft to cover almost the whole country. So, for example, if I'm in Tamale and you want me to do an evacuation from Boku, all I need to reconfigure the aircraft, pick the aeromedical evacuation team, and I can do that. We do that for the UN. We do that for some of the countries in the sub-region. So that is how.
So my point is that we know you have the military aircraft. We also know you have the helicopters. It's not the aircraft may not be able to land in Boko because we don't have an airport there. You can land in Tamale, and yet you have helicopters. So do you convert the helicopters or reconfigure them sometimes to serve as air ambulances so that you can lift someone from Tumu, for instance?
Well, exactly so. So, for example, we have helicopter in Tamale. So that can do the mopping up for the fixed wings to bring them. Sometimes you want to do it door to door, from one hospital directly to another hospital. But that also may not have a landing pad for the heli. So like I said, that is our function as an Air Force, and we do that. But sometimes availability is also a challenge. But we don't have a specific aircraft that are packed for aeromedical evacuation.
Forgive me if I'm asking you too many questions, but the tertiary hospitals we have, do they have helipads?
I think they are here, isn't it? But I can understand why you asked that question. So what we do is we combine the national ambulance with the aircraft. So you move with the ambulance before we put you on the aircraft. But I think they have spaces around the hospitals where normally we can pick the patient.
Very well. Thank you. I think Ghana Airport Company can help us. Our air infrastructure, you support that largely. You also have your own clinic that you run. Have you encountered any issues similar to the questions I'm raising? How have you dealt with them in the past? If you haven't, how do you reckon we can deal with these issues that I'm raising?
In terms of accessibility?
Yes, so in terms of airlifting people, because we're discussing the air ambulance, for instance.
Well, our role is more or less limited to facilitating the process. So we are enjoying to make available maybe the parking space, get our clinic to assist in medically evacuating the people, maybe from the aircraft to the clinics, to the hospitals where necessary. So that is where we come in. And so far, I think our collaboration with the military has also been excellent in that respect. And so that's what we do.
What about patients who are going to be taken abroad? How easy or difficult is that?
Well, that has been going on as well, but it all boils down to the process of notification. Now, typically, for that to happen, there ought to be notification to the Ghana Civil Aviation Authority as well, because the ambulance ought to be cleared to land at an airport in Ghana. And then we make the facilities available in terms of the parking stands for the aircraft and so on and so forth. And when necessary, we then involve our clinic to get in touch with those conducting the medical evacuation itself. They are also equipped, they have the ambulances and the equipment that they use. And so then we facilitate the process and we make it happen.
Are there some challenges you'd want addressed as we move forward? What are some of the key issues you think should be handled immediately to ensure the universal health access?
Well, challenges, I think the Chief of Staff has mentioned quite a few already, but what we would say that to the extent to which our objective is to facilitate, it's a question of receiving a notification, making the stands and so on available, getting our clinic involved, and we get it going. I guess maybe you may be thinking now about establishment of maybe a medical evacuation entity, kind of, where you have a standing aircraft and so on and so forth. It doesn't appear we're there yet, but I'm sure we'll cross the bridge when we get there.
I don't know if we are belaboring the point on air ambulance. Please give the microphone. You wanted to make an intervention.
Yes, you see, Chief, when you're addressing health systems, you don't address them in isolation. I remember the last senior managers meeting that we had about 5 years ago. Prof. Akosa, who is here, said something, that we need a national dialogue. And this is a man who has been in Kolebu and he has been in Ghana Health Service. And he had different perspectives, which I had, and we'll be discussing it all over the health system itself needs to be restructured. All the things we are talking here, there is something we call the star of life. If the ambulance man gets up now, you see his badge. That star has 6 arms. That's how health systems are organized. The first arm is early reporting. If we collapse here right now, tell me the number we'll call right now, that it will go to a control room, which will dispatch a qualified paramedic into this room. And that national control room has to exist. Then when the call comes in, it goes to the next, which is early response. How do you get there? Now we are talking about air ambulances and all that, which is a fair comment. And I remember that I've been with ambulances for 7 years. We started it, so I know exactly what happened within my term. It's not cost effective to have an aircraft sitting and waiting, because the pilot, you can't even pay him. Chief, ally. So you need to deploy it in a way that your resources can be maximized. Then from there, you go to arrival at the place. What happens? Care at the scene side. And we still have people that our community level, and even you and I, who are not in medical field, somebody collapsed now, his water will pour on him. We've not been educated to do any other thing beyond that. And that unseen care is the bystander. Then care on transit. What kind of ambulance are you deploying? What kind of aircraft are you deploying to pick that patient and give him the best care whilst on transit? And then definite care when he gets there. Because they would have communicated from the very time they got the first call. In that call, to say this patient has neurosurgical problem. Don't take him to police hospital. Take him to Kolebu, which has a neurosurgeon. Everything is prepared. He gets there, he goes to the theater, and he starts again right there. He's being received in 3 seconds. He moves to radiology department, gets his scans, he goes straight to the theater, he gets operation, or if not, he goes to his department. You know his department, right? So this is how health systems are functioning. And we need to have that dialogue again to see, because right now what is happening is that...
at the health service?
Yes, we do have. But
on paper?
No, even practical.
Okay.
What is happening is that each health institution is fighting for itself. And we are duplicating efforts. And people are not giants enough to develop a health system on their own as individuals or as an institution. You asked a question about helipads. We only have in Confanoche, okay? University of Ghana Medical Center, quaternary base, is also trying to put up one.
Kolebu does not?
No.
That's our number one?
No. No. But places can be created. But having the helipads alone is the system that needs to be developed, where you develop the system in a way that is holistic. And that even has to do with the organogram of the system itself.
Whose job is it to coordinate these things?
Okay, so in the health sector, you have the Ministry of Health, okay, which is the mother of everything. And then you have the agencies. So the ministry is to coordinate this and come out with a policy directive as to how the health system should function. Now, the universal health coverage you are talking of, if you read, they have plenty. You have the concept, you have the pillars, you have the principles. There are about 11 of them. The pillars, there are about 3 of them. And they have the different type of health system develop, whether the Canadian system, the communist system, or the private system. Ghana, we are hybrid. And in that hybrid system, your health service structure should be developed in a way that is hybrid, that responds to the common Ghanaian. I'm always thinking of myself. Traveling to Navrongo, if I fall, what happens? Nothing. They'll put three. They'll pluck and put on me. And that is what we should be talking. How do we avoid that to occur to us? That's my objective.
And emergency response at accident scenes, how people handle patients from vehicle accidents. That's another issue that we can discuss. People don't even know what to do, how to bring people out, rescuers, and all of that. It's a big problem. Okay, the picture is a bit gloomy. Let's try and find solutions, positives, moving forward. And let me start from you, Hanson. Moving forward, before I go to the audience, how do we move away from here? How do we get out of this mess?
Well, are you describing the air medevac as a mess or the... No, I don't think, I think with all humility, I think we are one of the best you can get in the sub-region. I've worked in Somalia, I've worked in so many countries. I mean, we have one of the best responses that I can think of.
But if we compare to Somalia,
no, I'm saying I've been to countries. I say I've been to countries where, and even as an aviator, I mean, as an Air Force person, we do this even for the UN. So, and if you compare, we have the facilities, we have what it takes. So it's not that of a mess, but I think that the capacities we have in this room tells you what we have. We have more than what. Probably, what I think you are referring to is how we can improve the coordination and the systems so that we can. Medevac is not It's not, I mean, it's one of the last resort that Ghana is not big. I mean, you can drive 4 hours between Kumasi and Accra and bring a patient. If you look at the new ambulances which are out there now, as one of the best ambulances that you can get, it's more than a hospital. So I would rather say that, and just to help you understand how we do the referral in an air medevac, if you don't delegate it to the centers, then you delay the system. So, for example, if we have to do an evacuation from a place like Bimbila or somewhere, the doctor will call the base commander will call my operations. I give my operations director. We issue a task order, and then we move the patient. As to the medical aspect of it, I will leave it to the doctors to talk about. Now, how do we move forward? Moving forward is not actually buying an ambulance and putting it out there. That is not the issue. I think it is the technical aeromedevac evacuation teams that they are available. Because if you have a patient on the aircraft, you need somebody to respond to that patient. And what I was referring to, we do in other countries, we do mass casualty evacuations where you have about 6 patients and you need to take care of them in the aircraft. Some of them you have to perform some mild operations on them so that they can breathe, the pressure and that kind of thing. So I think the systems are there. We should identify them, strengthen them, and if we can do just about 10–50%, air medical evacuation shouldn't be a challenge at all. It should not be a challenge. What would be the challenge is availability of the assets. But if we have the assets and you call, I will do it. If you call, we will do it for you.
Okay, thank you. Mr. Tego?
So, want to talk about training, enhancement of training and service sustainability. We have people now providing the service. What about tomorrow? So we need to make sure that we train more people, enhance availability of that, and then also make sure that the quality of the service that is being provided. Let's say if there's a medevac, the people who move the people from the aircraft to the ambulances and to the hospitals and so on, the core should also be improved upon. So that's it.
Thank you so much. I always say that if there's nothing to... You wanted to say something? Okay, let me... Okay. Okay, yes, the way forward. All right, please.
Sorry for this, because after being in the system for a while, anytime I attend a meeting, I don't want the regular thing. I always want something different. And I always want to see myself as the patient. And to me, the way forward, the first thing is that it's a mindset. We've talked in Ghana Beyond Aid, this, that, policies, they are all mindset. If we change our mindset and say that we want to work together, we'll get things right. If we don't change our mindset, it's never going to work. I've seen a lot of agents, institutions want to become agency. Agencies want to become this. It's just the mindset that in the life of every generation, that spirit of togetherness has to come true if we want to make a difference. If we change our mindset and say we want to treat the common Ghanaian, because I do agree with the gentleman, if you call an air ambulance, you get it. And I don't want this to be focused on air ambulance, but I don't know, besides the military people, we the common men, we don't even know the number we will call. And if there is something to pay, we can't afford. So we should be thinking about how do we make it affordable. That's the whole thing about universal health coverage. And it shouldn't be about just air ambulance, but the health system in general. And then we should have that seamless health service in our referral and gatekeeper system. If we live here and we are satisfied that they will have a communique to agree with the other health service delivery systems, that when you have this, your hospital record system talk to each other. A patient doesn't have to carry his folder, move from this hospital to the next, no. Or stay 5 days in Kolebu because he needs transfer to Rich. Or 7 days in Rich because he needs, no. But those things can be done.
Thank you. I like the positive approach. I've always said that if this government should not, and coming from a journalist, it should be very expensive. If this government should not get any credit at all, we should at least be celebrating the 307 ambulances that have been brought. If every government does this at least every 4 years, I'm sure we'll be getting somewhere. So, Mr. Ambulance Service, we've given you 307 ambulances. I mean, the last time we saw one was carrying cement, but that's not the biggest issue. Can I have someone take the microphone to him, please? Yes, and then to move around the audience as well with a microphone for me. So want to know the issues we've raised, the preliminary issues, the issues of, we know you've changed your number from the regular ambulance number to a new number, how the response is, what is your coordination with the hospitals like, and then even if you have another coordination with the air ambulance or the armed forces as well, please share with us. We want to understand. You can take off your mask over here. Thank you.
Good afternoon, everybody. Mr. Chairman, Umaru, thank you very much for the question. And I'm happy that as a country, we have come to a point where we've realized the role of pre-hospital emergency services. Gone were the days where we would have spent most of the time dwelling on in-hospital services. And the discussions today is just bearing to the fact that as a nation, we need to look at how we can address emergencies outside of the hospitals. Dr. Kaba was making a very important point, and like he said, we should always put ourselves in some of these discussions. If we should fall down today, how is the response going to be like? Where is the ambulance going to come from? Even amongst ourselves, how many of us are competent enough to perform certain basic first aid maneuvers to resuscitate as individual? And so I'm very honored to be here. I bring greetings from the Chief Executive Officer, Professor Ahmed Nuhu Zakaria, who would have loved to be here. Coming back to this discussion, over the years, Doc was mentioning, we have made conscious efforts to improve pre-hospital emergency care. Sometime between 1997 to 2000, we could remember the Kumasi City Ambulance and then the Sekendi Takrade ambulance services. These were all regional interventions that did not yield so much. But again, thanks to the government initiative of setting up the National Ambulance Service in 2004 with just 7 stations. Today we have seen an injection of 307 ambulances, and we have 297 stations across the world, across the country, in every region. As we sit down here, we should be pleased to know that if there is an eventuality or an emergency, we could have Atomic Ambulance Station, Jawulu Ambulance Station responding to us in record time. So back to revolutionizing the service and how far we have invested. How do we revolutionize this service? I would want us to take it from the 3 model perspective, which is basically used in identifying the maternal mortality ratios. One, we are talking about 3 delays. One is the delay in you yourself taking a decision to seek medical care. Because if we invest in the hospitals, the district hospitals, if we have the helipads, if we have the aircraft, if the population does not decide that they want to seek help, it would not lead to anything. And so we need to take a decision to educate the public, educate ourselves on basic first aid maneuvers. We also need to make education and first aid and basic training an integral part of our education system. When we talk about the outside world, it's very easy for you to get a child to pick up a phone call that my dad is not breathing well, my dad is not responding to my call. And the emergency dispatcher would be able to take this individual through some steps to revive this person. This all comes with education, 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 education. In our culture, or in our part of the world, traditions, perceptions, beliefs affect why somebody would decide to either call for an ambulance or not call for an ambulance. People don't know that if you call, Doc was making a point, how many of us know that when we want to get in touch with the National Ambulance Service, the number to call is this or that? and it's actually 112. When you call, is it just instantaneously that an ambulance will be dispatched? No. There are a series of questions that you would have to go through before an ambulance is dispatched. These are informations that the community as a population we need to know. And if we want to revolutionize our services and our healthcare, we need to start from the things that we can easily change. And perceptions, traditions are not easy to change, but we need to educate our communities on their role in emergency services. The second delay, which is caused by actually accessing the help, not just accessing the help, but then in terms, it has to be equitable, it has to be in record time, as in terms of the internationally accepted response times. Currently, we have a response time between 20 minutes, and this is largely because of the disparities in terms of communities. If you go to some place like Nkonya to Rara, which is about 1 hour 30 minutes, if you call an ambulance from these areas, those areas are going to increase the response time. How do we then bridge the gap and then bring healthcare services closer to our people, closer to our communities, especially the rural areas? How do we do that? We need to improve and increase the number of fleets that we have. Yes, we appreciate that we've taken delivery of 307 ambulances, but is that enough? We are constrained in terms of the down times when an ambulance breaks down. Currently, the practice is that you would have an adjoining constituency responding to that emergency case. We need to have 2 or more ambulances in these areas because taking into consideration the population size, taking into consideration the disparity in terms of the communities. In Accra, you would have communities that are close, but let's go to the Upper East, let's go to Boku, let's go to Upper West. How are the communities structured? And so there is a need for us to increase the number of fleets that we have. Now we are in the technological age. If we want to improve on access, we need to employ more information technological tools. Currently, we are using the GPS post. We also have the Mbwa app in terms of tracking, the GPS post in terms of calling an ambulance from your phone. And that prevents or improves the response time in terms of when an ambulance is responding, we now don't have to come to the mango tree, come to the kiosk and all those things. But how many of the population are aware that we can access the service through these mediums and through these platforms? These are platforms that we also need support to improve upon, so that wherever you are, whether it's domestic, industrial, or any form of emergency, you can have access to the emergency services. So we need to improve upon these information technologies. Now let's go to the hinterlands as well. When you go to our rural communities, they don't have the luxury of having the many ambulances that they have. And so other collaborators like the Catholic Relief Services and then United States Aid, US Aid, and National Ambulance Service are adapting the Tricycle ambulance system, where tricycles are being converted into ambulances, and then they can be able to transport people from one community to the other. We are collaborating so that there could be that form of transferring of patients, and then transferring of patients from these tricycles into ambulances. When we look at the air ambulance discussion, that is a discussion for the future. That is a discussion that is relevant, and we need to have that. But in the meantime, how do we ensure that those in our rural communities, the poor, the marginalized, which are the focus of our discussions today, how do they have access to these services? In the absence of the air ambulances, the tricycle ambulance is a concept that can also be adapted. And if implemented, we can improve upon access to these various communities. On the third delay, there are other points as well, but I wouldn't want to take the whole floor. There are other points that is a third delay in terms of the quality of care that you receive in the pre-hospital setting. Yes, we need equipment, we need the personnel. Often when you talk about National Ambulance Service, everybody's mind just goes straightly to the vehicles. But that is not just the vehicles, but we are talking about a human resource. We are talking about the equipment that they need to work under, the office infrastructure, residential infrastructure. And these are things that if we look at and we take a closer look at, and as this whole discussion is gearing towards pre-hospital, it means that we all have a sense of need to improve this area. And just before I end, I would also want to thank our collaborators, and then as well as the media. If we are going to educate, then we need the media, we need the Ministry of Education, we need Ministry of Communication. Everybody, it's a whole collaborative, we all need to get on board, because this discussion would affect all of us, if not today, tomorrow. Thank you very much, and I think we would all engage ourselves better.
Thank you. Please please give the microphone back. Just a few things to clear. How do you communicate with the hospitals? Do you have challenges, or now you're okay, so that you don't, use a siren in traffic, come to Kolebu and they say, oh, sorry, you should have gone to 37 or somewhere else? Okay, so in terms of emergencies outside, once a call comes in, it goes to the control room. That's after calling the 112. There is a system where they call the hospital to make arrangements for bed availability before the ambulance moves to the actual facility. In terms of hospital referrals, then before even a patient is moved from one hospital to the other, the referral policy states that the initiating hospital has to communicate to the receiving facility to make arrangements even before you call the National Ambulance Service. So those arrangements are in place. As a service, we're also moving a step further to also institute the pre-hospital information management system. That would also give us one platform to have all these hospitals on that platform. We are going to be sharing information on bed availability, on doctor availability, that's the specialty availability, and then for every hospital, we know the kind of laboratory services and radiological services that they perform. So that if we have that system, at any point in time from our control room, we should be able to tell the availability of beds in the various hospitals across the country, as well as... How far advanced are we in developing this system you talk about? Or we have not even started?
It's at the start stage, yes.
By when should we expect this system to be rolled out?
We are still in discussions with the various hospitals. I know we've had discussions with Kolebu, with Ridge, and initially with the major hospitals, and then we'll then scale it up.
Final question. Why do you ask people or relatives of patients to pay before an ambulance comes to pick someone from one place to another? It happens, so that's a fact, it happens. We receive calls. So if it is wrong, then let us know that it is not right. If it is right, explain to us why and how much.
Okay, for how much, I would not be able to go into that. In terms of financial support, there are instances where some referrals are being costed. Those referrals are referrals that are normally, because we expect that if someone is in a hospital, the person will be billed for the services that are being provided. And if during that process, a referral would have to be made, then it means that those referrals will be inculcated into whatever costings that the patient has. We're looking forward to have the National Health Insurance. I'm sure that was also part of the discussions that we were going to have, to come in to also have a dedicated source of funding for some of these services. These are discussions that have been had outside of this room, and I'm sure at an appropriate time.
Currently, my health insurance doesn't cover ambulance service.
No.
It does not,
yes,
okay.
Yes.
Thank you, but if someone should be picked from home, they are not supposed to pay.
They are not supposed to.
But if they are to be picked from one hospital to another,
yes,
they should pay.
Yes, please.
At an accident scene, you can't be picked for free.
You cannot.
Thank you so much. Thank you so much. Yes, let's go to the audience now. If you have a question or a comment, please. Yes, there's a micro. Yes. Thank you so much. So the microphone is making the rounds. Yes, I'll come to everybody. Thank you. Let's hear comments, questions. Yes.
So I'm happy about...
Can you introduce yourselves when you do?
My name is Emmanuel Chenga, doctor.
You can also remove your mask so we hear you. Thank you so much, Doc.
My name is Emmanuel Chenga, doctor. A former executive committee council member. I'm happy to see Dr. Kaba and the Air Force people here. The concept he mentioned about bringing the various actors on board was a concept I developed on behalf of Gaqhi made a presentation to the ministry in 2015, 2016, 2017. And the idea was to start from the community, where we register all the pharmacies and choose one of them to be designated a community pharmacy. Where we register all the labs, I'll show you after we leave here. I have it on my phone. Where we register all the labs and choose one. Where we register all the X-ray facilities and choose one in every community or constituency. Where we register all the doctors who are staying there. The idea is that I don't have to go outside my community. If I have a chest pain, I should be able to call a dedicated center in that community where it will be received. And knowing the doctors in that community, they can call me. I can do a short interview with the patient on the phone or the family. If he needs lab, even before he goes to Kolebu, and there's a lab registered in that community, I can send that patient to that community to do that lab even before he goes to Kolebu. If it's medicine, you see, the emergency is not only in terms of acute. Sometimes all that the patient needs is to get a certain medicine. And he has to travel all the way from Dansoman to Osu to get the medicine at a certain facility. But if you register one pharmacy at Kolebu, at Dansoman, as a community pharmacy, that pharmacy can be stocked with all the medications that will be needed to cater for all kinds of emergency. Pharmacies don't stock most of the emergencies because we don't use them. And because there was one case of one young boy, 13, who died because he needed propofol, which is used rarely by anesthetists. But no pharmacy was able to stock it because when they stock, it expires on them. But if you have a pharmacy here at Atomic, designated a community pharmacy, then that propofol can be in that pharmacy, supplied by the community on behalf of the community. So I'm just saying that. The second thing I want to talk about is what is called, you Google afterward, health in all policies. If you can have the concept of health in all policies, where every policy is looked at in the context of its health effects, benefits, and consequences, whether it's the rules you want to construct, whether it's so-and-so we want to import, whether it's where we want to cite the industries, or the education of our students. Dr. Manuva knows we have tried at University of Ghana to get it that every student who comes to University of Ghana, by the time he finishes the final year, should have a training in first aid. You understand? Should have a training in first aid. It may not be compulsory, but it should be a requirement that by the time you finish University of Ghana, you should have had a training in first aid within the 4 years. It can be done in the first year, second year, third year, and fourth years. That's universal coverage because we have people coming from all our towns and villages who are accessing tertiary level, whether it's University of Ghana, Kumasi. So if you can do things like that, I'm sure the issues that Akaba talk, the issues we talk about, the pre-service, how people can assess, how people have mindset, I think we can change people's mindset. So I just want to mention those two things. Health in all policy. I'll discuss it with you afterwards. And then secondly, this community-based emergency or access care system take into consideration. And then finally, if our parents' institution in Gaqhi can be made to understand that health is not a core business. Health is beyond core business. COVID has shown us that without health, you don't have any institution. You don't have any factory. You don't have any institution. If you can make our institution to realize that you only come to work because you are healthy, not because you are an MD, okay. Not you are the chief of the Air Force. You only come to work because you are healthy. Then our mindset, Dr. Kaba talks about, can change. And a lot of the things he talks about, ambulance can be provided easily by churches, can be provided easily by families can be provided by institutions. That's all the three things I want to comment about.
Thank you, Dr. Chaga. There's a slight change. So I'll let you all speak. I'll bring the microphones to you. But the idea is that when you ask your questions or make your comments, the panelists will respond. The main address has not been given. This main address will capture a number of the keynote for today has not been given. The keynote will be capturing a number of the issues that we intend to raise questions about or make comments about. So the decision is that let's get our main speaker to give us address while the panelists wait. Then when your question comes through, maybe our guest speaker or our main speaker would have addressed that already or can address that for you. I think that makes a lot of sense, and it's a proposal that has been made, and we have to go with that. In the meantime, the technical crew, someone has left their phone here. I don't know if it's from the promoters. It's been lying here for a while, so kindly pick your phone before it becomes a health hazard. So at this stage, I want to invite for the main address for this afternoon, Brigadier General E.C. Saka, who is with the Ghana Armed Forces Health Directorate. Please, let's welcome him with a round of applause.
Permit me to start by expressing my gratitude to the organizers for not only inviting me to be part of the event, but also as a main speaker on this special occasion. I would crave your indulgence to stand on the laid down protocol as expertly laid by our president. I don't think I could do it any better. Discussions on matters of health are important and necessary discourse in our everyday lives. As a nation, Ghana, like all other countries the world over, aspires to achieve universal health coverage for her citizens in a bid to ensure the good health of its citizens and contribute to boosting socio-economic development. Ghana has defined universal health coverage as a state of affairs when, and I quote, all people in Ghana have timely access to high-quality health services irrespective of ability to pay at the point of use, unquote. The ability to pay bit, in my view, falls largely within the domain of the National Health Insurance Authority, which is working assiduously towards this. The bit on timely access to high-quality health services is where I think the Ghana Association of Quasi-Government Health Institutions comes in. Hence, the theme for this 7th biennial conference, which is Revolutionizing Health Access for Universal Health Coverage, Gaqhi'S turn. Today marks a special milestone in the history of Gaqhi, the health sector, and our beloved country as a whole. Mr. Chairman, the promptness and expertise with which an emergency care is delivered is a hallmark of an effective, efficient, resilient, and a safe health institution. Ghana will soon turn 65 years since attaining independence. Therefore, it is no longer acceptable to have a healthcare system that is discriminatory in terms of access to quality healthcare, especially considering who, when, and where a person is. Neither is it acceptable for an erratic first responder response in emergency situations on our roads, at homes, or at our workplaces. We're here to tell Mother Ghana that Gaqhi, as a collaboration of patriotic citizens, will do for the nation in this regard. Quasi-government health institutions and their parent organizations have special skill sets that are unmatched in the health sector. Apart from the general medical skills, Gaqhi has within its fold personnel with indispensable skill sets in areas of security, aviation and air traffic control, border control, research, engineering, firefighting, radiation management, etc. These need to be fully optimized and synergized within and between our various agencies. The ultimate aim of the concept about to be proposed will be to leverage on the skill set of our sector organizations to impact positively on healthcare in terms of access, safety, quality, and innovation. The proposed approach will be done through the adoption of two strategies. Under the first strategy, Gaqhi would leverage on its aviation skills by introducing air ambulances and a special medical brigade to ensure that quality health care reaches every part of the country. To achieve this, it is proposed that the country will be divided into 5 latitudinal zones. These will be the upper, northern, central, southern, and coastal zones. Again, longitudinally, it will be divided into the western, middle, and eastern corridors. By this, a total of 15 jurisdictions will thus be obtained. At the center of each jurisdiction, there would be an air ambulance station comprising a helipad, resuscitation or procedure area, check-in and passenger waiting area. There would be medical brigades that will be stationed at these strategic areas. With this arrangement, no area in the country will be left uncovered. And in our estimation, it should not take more than 20 minutes to respond to or reach a distress call. To make this more effective, high-level medical staff will be moved by air to assist designated facilities in respective jurisdictions to carry out advanced management, thereby treating patients in their comfort zones, as well as increasing the capacity of local medical teams. The second strategy would be to increase the skills of persons who act as first responders across the country. The methodology is to encourage the institution of first responder training skills in our tertiary institutions, including universities, technical universities, and colleges of education. This would ensure that all graduates from these institutions become competent first responder personnel on our roads, homes, and offices, while the colleges of educational graduates would serve as ambassadors for primary and secondary education institutions. If this is effectively done, the end goal of skilled first responder services and prompt second responder access would be achieved. In the hands of Gaqhi, this would be a feasible and cost-effective project. This is because skills for warehousing, management, and maintenance of these fleets are already in existence. It is anticipated that ultimately 15 air ambulances and 5 planes, making 20 aircrafts in all, will be brought on board for effective operationalization. Additional resources, including the acquisition of land, are things that we hope our distinguished traditional rulers and district assemblies will be glad to assist with. Gaqhi is also conscious of other cost implications of embarking on such a project. However, we console ourselves knowing that nothing great comes easy. The following are some of the numerous benefits likely to accrue if the project takes off and runs effectively, as quality healthcare would come to the doorsteps of, 1, people in areas inaccessible by road, such as the overseas areas, people in underserved and hard-to-reach communities, farmers across the country. Every community and all people living in Ghana will avail themselves for healthcare. Additionally, huge benefits would potentially accrue to the following entities from the project. 1, the tourism industry. The presence of air ambulances in the hinterlands would encourage tourists to explore the country widely, as it would serve to provide medical assurance to them in case of ill health. 2, foreign nationals or development partners visiting any part of the country will be reassured. Our parent organizations, it would aid in obtaining information for parent organizations involved in surveillance for prompt action. To other neighboring countries, citizens of neighboring countries, through the appropriate channels, could make use of the services as and when they have need for. For this project to see the light of day, multi- and intersectoral approaches would be adopted. This would encompass all stakeholders needed for the realization of the project. Ghana's roadmap to attaining universal health coverage 2020 to 2030 takes inspiration from the National Health Policy and sets the strategic direction for the health sector in the next 10 years. It also emphasizes health in all policies with the aim to stir action in other sectors for health and human capital development as articulated in the National Health Policy. The goal of universal health coverage, as stated in the document, is to increase access to quality essential health care and population-based services for all by the year 2030. In fact, the overall goal is to attain at least 80% coverage of Ghanaians having access to essential health services. This project by Gaqhi will therefore contribute immensely in achieving these goals and beyond. As a result, we all need to come on board to make it a reality. Truly, it is Gaqhi'S turn. Thank you very much.
Thank you so much. I think we should give him another round of applause. Thank you. So that's Brigadier General E.C. Saka, Director General, Medical Services at the Ghana Armed Forces. Now, our panel here is actually incomplete, so we're going to make it complete. We've heard from the Armed Forces. It's fair to hear from the Ghana Police Service. The police hospital is critical, as well as the 37 military hospital. We are grateful and appreciative of the fact that we have been joined by an official with the Ghana Police Service who is going to speak to us on their own interventions and their perspectives to dealing with health care delivery, universal access to health. So, Madam, if you could take the microphone to the back and hand it over to Dr. Ewusi Emim, his Director, Police Health Services. Doc, you're welcome. Please speak to us. Your audience is ready.
Thank you very much, Mr. Chair.
Please take off your microphone, not microphone, your mask, so we can hear you. Okay. Thank you.
Thank you very much for the introduction. Mr. Chair, all protocols observed. I'm very honored to be here this afternoon. I should have been here earlier, but just as I was to come, there was a critical issue I had to deal with, and that kept me delayed for some hours. So I'm very sorry for coming in late. I think the theme for the biannual conference is very apt, and in total, as a group, as my good friend Brigadier General Saka said, the Gaqhi group, we have a set of skills which, if harnessed, will go a long way in the process of delivering quality access care to the ordinary Ghanaian wherever he will have to be. The Ghana Police Service have an emergency team, and the hospital also have an emergency health team. And we collaborate very well with the Ghana Armed Forces Medical Services and also with the Ghana Air Force in terms of evacuating some people from various parts of the country when the need arises. Though we are working, like I said earlier, I don't think everything is structured or formalized, and that if we can get a group to really take the lead and take the bull by the horn and make sure that our aspiration comes to bear, then hopefully we can achieve the things we've listed as wanting to do, so that this issue of dealing with medical emergencies could be well attended to. I think basically the issue with evacuation, especially when is the RTAs, road traffic accidents, is to do with the initial management. And I dare say most Ghanaians are not skilled in the aspect of resuscitation, let alone knowing how to lift patients. And you realize most of the time the ambulances may not be the first group or cars to arrive there, but rather the ordinary citizens. And they carry subjects anyhow into taxis, push them anyhow in, especially assuming there is an issue of cervical injury. And that really worsens the situation. So the Ghana Police Service and the Ghana Police Hospital is available. Whatever we need to do to make sure things get on and work well, we are available to do so. I don't know what other speakers have said, and I don't want to be repeating what others have said. So on this note, I'll give the microphone out, and thank you very much for the...
Thank you so much, Doc. You have actually complemented the conversation so well. I was even wondering if you were listening to us before you came. Thank you. We appreciate it. We can now take comments and questions. Yes. I'll restrict all of you to one question each, please.
Thank you very much. So I go straight.
Introduce yourself and then.
Thank you so much. So I go straight to it. My name is Moses McLean Abnori. I was introduced earlier in the morning. I want us to focus a little bit on the mindset. We are a small country of less than 48,000 something. with all the mineral resources we know. So we don't need to comment on it again. Because we've been told since independence that we are rich in every sense. Why are we here today? And I just want to draw attention to something small, because my understanding of universal access to healthcare hinges on two main things. Where you are, what is happening to you, your access to the health facility, or the other side, whether you have the money to access it. For the financial aspect, we don't also need to talk about it. I ask one question and I sit down. What is preventing Ghana for improving our sea transport? For example, from Maxim down to Accra, we can eliminate all these articulated trucks, the timber cars, and what have you, and send them there. Every medical personnel here will tell me that perhaps apart from malaria, the next thing that is killing us is accidents. If I have malaria today and I get the right medications, I will not visit the hospital again with fractured something. But if I get one accident, the doctor, the health facility becomes my friend till I die. Can we rethink? Thank you.
Okay, thank you so much. Thank you. Yes.
Yes, I'm Aziz, the immediate past national vice president. Yes, for Gaqhi. I'm Nuhua, I'm coming from Tamale.
Okay. Have they paid your end of service benefit yet?
No. Yes, I'm happy Prof is here and then Dr. Kabatu is here. When we talk about universal access, I think we are just talking as if somebody has to only emergencies. It's not only emergencies, even the cool cases. But I want us to look at two basic things. One of them that I used to know we were doing before, is getting the people, and I think Commander, the last speaker said, how expensive is it to get the expert going to the ground rather than the reverse? We were doing it before. Two of us would move from Kolebu and we go to all the regions, one after the other. May the soul of Dr. Kwenu, the urologist, rest in peace. Professor Koti, that was the peak of it. And I'm sure that one broke some of us down. We were doing ENT outreaches. For Gaqhi, up to now, I haven't stopped doing that. What I think we can be doing is preferring solutions. Identifying the issues is one. Preferring solutions in our own little way is another. What stops us in our own little corner? Trying to go to those people and offer some level of services. What stops us? But we are all now expecting to fly the people to Accra or whatever. What stops us from going the rivers? As I sit now, there are about 3 districts that has never never had a doctor. In the northern regions, they are just about 20 minutes away from Tamale. Drive. They don't have even a single doctor. Meanwhile, in Tamale, there are about 120 doctors lying down, sleeping, and waking up. What stops us? So it is in the mindset. Somebody ahead, it's the mindset. Okay. And the mindset, you cannot put it on helipad and whatever. What is the mindset? What is stopping us? With the number that we have, what stops us?
Thank you.
From moving to the people, and then giving them the service that they have, giving them the resources that they have in their comfort zone, and then I think the end will be talking something. So I think, yes. Let me stop. Let me add, what stops us? The money they are going to use to buy these plenty aeroplanes. How many of the facilities will you build to get the people to man it in those areas? Let the people have it very near them, and that one will solve a lot of this problem. Okay. In addition to the seats.
Thank you. Please bring the microphone to the middle. I'll come to the middle. Yes.
Thank you very much. My name is John Yamba. We are looking at Gaqhi'S 10 to contribute towards universal health coverage. I come from a university. How do we do that? We have about 400,000 students in the universities currently. And one of the effective ways to contribute to the coverage in terms of the health insurance is just to insist that the students that come to us are all registered with National Health Insurance. It should be part of institutional policy so that every fresh student and continuing student is registered with the National Health Insurance. At least this will bring down the cost that comes to the individual when they visit the health facilities, in addition to providing quality health services ourselves as members of Gaqhi. Thank you very much.
Thank you so much. There's someone behind him. Yes, the lady.
Okay, my name is Dr. Ame. I'm the CEO of the Trust Hospital. I used to be with the Ghana Health Service not too long ago. My question is that how do we, as Gaqhi facilities, benefit from this medical evacuation thing that is going on? Because our reach is nationwide. We serve a large number of people, SNIT staff across the nation, and sometimes somebody needs to be evacuated from somewhere to our hospital here in Accra. So how could we collaborate with the medical evacuation exercise, and who would bear the cost? Thank you.
Thank you so much. Please, let's go to the last wing. Do you have hands there? Yes, come to the front. Yes.
Thank you, Mr. Moderator. My name is Dr. Vitus Anab. I'm the General Manager for Health Services, Ghana Ports and Harbours Authority. The ports are always forgotten of. You see, we've been talking about, it's all about air, until Ms. Abnori mentioned how about sea transport or marine transport. Even when SARS came to Ghana, they forgot about the port. When COVID came, they forgot about the port. As we speak, the port has not even got any ambulance which has been supplied by or donated by the Ghana Ambulance Service. We don't have. We buy ourselves. And the ambulances we're using, of course, will not be of the same standard because of cost. My questions are 2 or 3. Does the Ghana Ambulance Service...
Can you limit it to 2 for me, please?
I think...
Because you've been neglected for long. I don't want to neglect you.
So give me more time.
No, 2.
Thank you.
2, thank you.
Does the Ghana Ambulance Service accredit ambulances over there? Across the country? There are so many private ambulances from different, maybe organizations have their own, some privately owned. Does the Ghana Ambulance Service accredit? Did they inspect those ambulances, see what is in them? Is there a reason why, it's just one question, is there a reason why national ambulance have been donated to certain MDAs and ministries when certain areas across the country, critical areas need ambulances? Why are those ministries having those ambulances? What is the need in Accra here? When we have access to ambulance service in Accra, why should we donate or assign ambulances to various MDAs and ministries? Now, the Ghana Ports and Harbours Authority, we are the only border which was never shut or locked down throughout the COVID period. The airport was shut down or locked down. The borders are still locked down, but we were never locked down. Throughout, we operated. Nobody has actually even come to us to find out how we did it and how we are managing. I've raised this at a lot of occasions, and yet the response is not there. Port health is not equivalent to port management. Port health is very different. What they do is very limited. But how did we manage with all these vessels coming from across the world? I can give you an instance where maybe Chief of Air Staff, with all compliments, there was an occasion where a Korean naval vessel had over 300 crew on board, and we had about 295 of them being positive, testing positive for COVID. And we managed it with the National Emergency, the National Security Service, and they were evacuated. They had to send down about 2 aircraft. So Mr. Tego knows that. They had to send special aircraft to come, and with us, we were able to evacuate these people from the port and then they were flown to their country because we couldn't manage this huge number in our country. We really have to get certain things right. My basic question now goes, if you are doing these ambulance centers across the country, how do we access those centers? It has to be by road. You carry the victim from the hinterland before you can get to the center where you can airlift that person. Air staff said there are a limited number of helipads across the country. The Ghana Ports and Harbours Authority built an ultra-modern hospital called the International Maritime Hospital. We are the only hospital who has, we did it in collaboration with the Air Force because they sent us, we requested for and they sent us special experts who came and inspected and advised on how we should construct that helipad. And one helipad in the country currently, and built according to specifications. If the air staff can, Chief of Air Staff, maybe can attest to that, he will know. Because we were able to take the heaviest helicopter in the Air Force there. They landed there and took off there. They came to test our structure. Okay. But it is not known. That's why I asked who coordinates all these things. Yeah. Before a helipad is built, the Air Force must be involved. It's not just about the hospital providing space, and it's not about building it on top of the roof. A helipad can be on the ground. Ours is on the ground, and it's serving the purpose. The last one, as you've given the opportunity, is about, I think somebody mentioned it, universal health coverage is not only about acute medicine. It's not about curative care. I think the basis of universal health coverage is primary health care. And let us concentrate on it and look at it. I think maybe there will be other opportunities and I'll make other inputs. Thank you very much.
Thank you so much. Thank you. There are specific questions that you sent to the ambulance service, and so our boss is there. Let me take the two questions in the middle, and then we can get the response from the ambulance to you. Please restrict yourself to one, unless you are from Ghana Port. You are the only ones who would have dispensation.
Yes,
please
thank you very much.
Please take off your mask.
DSP Dr. Champon from Ghana Prison Service Health Directorate. What I would like to say about universal health coverage, as we are discussing as Gaqhi institutions, first of all, is that Gaqhi is blessed with a lot of institutions that if our competence are harnessed in Ghana, we will be a force to reckon with. Because first of all, you have the military, you have the police, you have the fire, you have the prisons, you have the ports, you have VRA, you have all the other stakeholders. And bringing our strengths together, we will be able to take the nation to where it's expected to be in terms of universal health coverage. To talk about universal health coverage, you can never go off without talking about the marginalized and the vulnerable in society. Normally, we normally say that people who are incarcerated are people who are, in quotes, outcast from society. And normally we don't discuss them. But there is an adage that if you have a place in your house where you keep your garbage and you don't manage it well, that garbage will overflow and mask the beauty of that house. Literally, if you think about it, you might think that people in prisons are, in quote, garbage. But if we don't manage their health care very well, it will become a national problem. Let me give you the statistics. The largest prison in the country is in Sanwom, in terms of population. Currently, it's having about 3,000 people in custody. Out of the 3,000 people, each day, averagely, about 5 people enter the prison from the society. In a week, averagely, more than 20 people come to prison. Some are coming to serve life sentences. They will never come out again. Some are coming to serve different sentences and they will come back to society. Averagely in a week, we have more than 20 people also leaving the prison and joining the society. So if you are talking about universal health coverage without paying attention to these places, where currently in Ghana we have about 15,000 and over people in custody. And all these people have varying health conditions because the prison itself, it's having certain medical conditions that are called prison-associated medical condition. In the world, about 10.5 million people are in custody. So when we are talking about universal health coverage, there is no way we can run away from people who are incarcerated.
Very well.
Some of the concerns are, first of all, emergency care. I was so happy when my brother mentioned that universal health coverage is just about primary health care. And if we have people in custody who have varying emergency care situations, and we don't even have a single ambulance, the ambulance that we had was even donated by a private hospital. There is no single ambulance to the prisons in the whole nation. So when it comes to emergency health care, they have to be carried in trucks, in 4x4s, and the rest. We should also be discussing as Gaqhi the kind of way we are feeding the people in custody. They are fed 1 cedi 80 pesos a day. If you find yourself in prison, that is what we are going to feed you with. And all these have a toll on the health of the people in prison. The last one is we have to discuss how we can have a prison hospital.
Okay, we don't have one currently.
Exactly. So we need one.
Thank you. Thank you so much. Thank you. Please give the gentleman with the smoke.
Thank you very much. I'm Dr. Killian Buampong-Konam.
Can you please take off the mask? We can hear you.
Thank you. I'm Dr. Killian Buampong-Konam from Airport Clinic. Over the past period that I've been with the clinic, we have been involved very actively in quite a number of medical evacuations. I just want to speak to the issue of cost. The Chief of Air Staff just indicated that it costs about $6,000 to conduct an evacuation. Given the current state of our, of health financing in this country and affordability, especially among the general populace, I'm just wondering how feasible this air ambulance proposal would be in terms of affordability, and to what extent are we willing to engage the private sector? Because indeed, even currently, there are a few private individuals or entities that are engaged in medvac. And the clinic works very closely with that. To what extent has Gaqhi as an organization engaged these people to see how we can partner to make this proposal of an air ambulance emergency response strategy a reality? Thank you.
Thank you so much. Please take the microphone to the journalist at the corner. She has the last question. We need a journalist hospital.
At long last. So my name is Sarah Ofori from GTV. My other question has been asked in a way, so I wouldn't ask that. I would ask one question. One thing about universal health coverage is about access. And I haven't heard any proposal from any of you about having a dedicated route or road dedicated for ambulance services. We all know the traffic situation in our country. Even in some places, you don't even have the luxury of space for cars to even shift a bit for the ambulance to pass through. We talk about building other infrastructure that may not benefit our citizens, but we haven't even discussed access to these health facilities. And also affordability in terms of even our new venture, which is the introducing the air ambulance. It's going to be just a preserve of the rich, those who can afford it, because we've been told that we are supposed to pay for such services anyway. So if you're not going to make that available to the poor and marginalized, then you didn't even start in the first place.
Thank you so much. Issues of priority. Let's get the answers now. The first one will be from the ambulance service. Lots of things have been thrown at you. Let's see if you survive. And please mention your name for us again. I introduced you in the beginning, but just tell us your proper designation so the media would know who you are.
Okay, thank you very much. I'm Tego Alfred, Deputy Director, Emergency Services. I'll take the first question from Doc, which was on inspecting and then licensing of various ambulances in the country. No National Ambulance Service does not inspect and supervise these private ambulances. There is actually the Health Institutions and Facilities Act, and that's Act 829. Under that, you would have the Ambulance Council, which is supposed to regulate all activities and institutions that run pre-hospital emergency services in the country. So that institution is supposed to oversee the licensing. In terms of ambulance vehicles donated to MDAs and MMAs, I'm not aware of that, and I think that's a discussion we can have after here. For the 307 vehicles, 297 ambulance stations have been commissioned nationwide, and other strategic locations have also been given ambulances to operate. And so for that concern, I think we can look into that later. For the various concerns in terms of, I also just agree with all comments that have been made in terms of access, in terms of cost for some of these interventions and innovations that we are bringing up. In terms of the air ambulance, like has been shared, my also concern would be that which kind of services are the communities going to get? In terms of the rural communities, is it that every transfer or referral, we would then have to evacuate such cases? And so these are things that I think we are here for and we will be discussing. Thank you.
Thank you. Thank you so much. When I was introducing my panel, I mentioned HEFRA, the Health Facilities Regulatory Authority. Unfortunately, my panelist was not available. Is my panelist back from HEFRA? Is anybody from HEFRA here, please? HEFRA. Okay. Let's take the concluding comments from the high table then. So we've heard a lot of the things. Maybe comments, if you have any question you want to respond to, just in 1 minute each.
All right, from my part, let me make certain clarification. I work in here as a government official, and but I always do believe that government cannot do it all. Each one of us have to be responsible for certain things that we do. The gentleman who spoke about doctors going to other places, when you read the best publications on universal health coverage comes from Thailand. And it was the doctors themselves who got up one day and said, look, we don't want to be in the capital anymore. We are committing to go to all the districts and work in district level. Government cannot do it all, and we all have to collaborate one way or the other. Two, most of these things we're talking of, you know, I was talking about when this whole thing started with the alma mater in 1978, where they say health for all in all nations, which is the same as universal health coverage. Our health insurance system is to look at the cost and how best are we handling it to take care of this cost. I remember when I was in ambulance service, I mean, we can throw all questions to the gentleman, but it's not fair because we are the same people managing hospitals. We get these young guys enthusiastic. They drive an ambulance with a patient. They run, come to your hospital, you say no bed. They are not to put structure in your place to receive the case. The next day they are demoralized. Two, how do we even sponsor the work of and the activities of the ambulance service? It comes with a huge cost. And now, so what I would actually want us to look at is it that, Gaqhi, what is your position in this and how best do we foster? And I'm happy that the General spoke about this air ambulance and clarify everything. Even if we start at the moment where we always have to kickstart, whether people can afford, they cannot afford, but we will kickstart. And once you kickstart and it's a policy, we'll have to find a way of embracing it and making it work. But if we want to get everything correct before we start, then we will never start. And I always tell people that in every book you write, you have edition 1. The next generation will write edition 2. It doesn't mean that you don't know what you were doing. We're giving that foundation and empowerment to the next generation. So I think if we look at it from that way, I think coming out with this beautiful proposal has solved a lot of issues for the future generation. Thank you.
Normally, I would wish to just give one comment to thank all the doctors and health practitioners here for your service to God and country. You know, if you move up north, you'll realize that doctors are giving their best. I will just make one comment on the cost. Sometimes you do Medivac only for the patient to come for MRI. Because it's an accident, they don't have an MRI, so we have to bring the patient for an MRI. Now, if you do that 4 times, you can buy an MRI back into the hospital. So, I congratulate the organizers of this forum, especially the Quasi hospitals, for this initiative. Air ambulance is not cheap, but very relevant. And I believe that this dialogue should not end here. And as I said, to thank you for bringing this dialogue up. For the Air Force, this is our mandate. And we don't do it because it is expensive or it is cheap or whoever. Once we get a request, the assets are available, we will do that. We will do it. So thank you again for bringing us on board.
Well, on my part, listening to the address given by the DG of the military health services, I think there are things that come to the fore. The issue of cost. Assuming we were to roll out what he has indicated, I know buying aircraft and so on and so forth is not that cheap. So the question arises as to what is the way forward. And I also make reference to a sentiment expressed on the floor, that indeed the possible way out is to strengthen the regional hospitals, so we don't end up evacuating people to Accra just for MRIs. So I think that the way forward, possibly, is to strengthen the regional hospitals to ensure that whenever there's a medical emergency, at least as a first step, the regional hospitals should be available. But going forward, in terms of where to situate maybe a medical evacuation brigade in terms of air ambulance, the Air Force is already doing a splendid job. So we should strengthen them, provide resources for them to continue doing that. And then the supporting agencies, the airport clinic, the military hospital, and so on and so forth, could then be given the resources to make that whole process even better. These are my comments.
Thank you so much. I think we can give our panel another round of applause, please. Okay. Thank you so much. Thank you so much. Really appreciate it. Thank you. Yes, you've been dismissed. All right, we need to get to the concluding part of the program. Before that, let me just do some quick acknowledgements. Linda Kusi is with the Clinton Health Access Initiative and her team. Please give us a wave. Give us a wave. Thank you so much. Professor Emmanuel Date, Amu State Kumasi, Vice Chancellor, represent the Vice Chancellor. Give us a wave. Thank you so much. Appreciate it for your time. Dr. Julian Ame is CEO of the Trust Hospital. Please give us a wave. Thank you so much, Doc. W. Omani Ajekum is Deputy Director, NHIA. We didn't hear from you, National Health Insurance. Where is he? Please give us a wave. Okay. All right, that's fine. Mr. George Akomia is Director, DMCL. Mr. Akomia, please give us a wave. Okay. And then Dr. Emmanuel Kuma is a lecturer at the University of Education, Winneba. Thank you so much. Thank you. Mr. Alfred Tego, representing the CEO of the National Ambulance Service, has done so much. We appreciate you for that time. Now, we also invited the Minister for Health, the man who said his image has been battered, when he appeared before the House of Parliament yesterday and contributed to the debate. Unfortunately, he could not join us this morning, but he sent a representative to deliver his address to us. So let's welcome Dr. Hafiz Adams Tahir, who is representing the Minister of Health. He's Director of External Health Cooperation at Ministry of Health. Dr. Hafiz, please, you're welcome. Please deliver your statement for us. And I've already given the caveat. It's not yours, so anything in there. Yes.
Chairman, Honorable Professor Ajimambedu Akosa, you deserve it, Prof. I think there's a list of a number of people here. Forgive me, I came late. I'll just have to read what the minister did tell me to read. And so the Speaker of Parliament, Honorable Alban Kingsford Sumane Bagbin, the Majority Leader, the Minority Leader, ministers and their representatives, Chief Executive Officers, Managing Directors of Gaqhi Parent Organization, the Vice Chancellors, Registrars of Public and Technical Universities, the Military High Command, Inspector General of Police, Dr. George Dampare, the Commanding Officers of Security Services, Sector Lead Coalition of NGOs, Executive Council of the Quasi-Government Health Institutions, distinguished invited guests, friends of the media, ladies and gentlemen, all other protocols observed. I deem it an honor to be the special guest at the Ghana Association of Quasi-Government Health Institutions, Gaqhi'S 7th Biennial Conference on the theme, Revolutionizing Health Access for Universal Health Coverage, UHC, Gaqhi'S 10. The theme is well chosen and appropriate, especially at the time when emergency response in healthcare is the current concern of the Ministry of Health. The theme falls in line with the government agenda on equitable distribution of health access to all. In order to achieve this, government has initiated the Agenda 111 project to establish basic health infrastructure across the country to ensure all people living in Ghana have equitable access to health care. In the recent past, government instituted such measures as provision of 300 ambulances to fulfill its promise of one district, one ambulance initiative. Establishment of call centers, introduction of telemedicine, deployment of drones for timely delivery of blood, anti-snake venom, and other essential medicine to remote, hard-to-reach areas to save lives. Recent digitalization project will also promote e-health, telemedicine, and e-pharmacy. Indeed, the introduction of aviation technology and air ambulances will, in synergy with the above, go a long way to bridge the skill personnel gap across the country. Swift and safe evacuation of patients to centers of excellence for appropriate health care will be guaranteed. Similarly, expertise can be flown to support the local medical team to provide services and save some capacity building initiative. At your last biennial conference, you indicated your desire to scale up first aid and basic life support training in your organization and tertiary institution. Gaqhi is privileged to be associated with educational institutions, particularly universities and teacher training colleges, where this subject could be included in their curriculum as a compulsory subject. The trainee teachers will in turn impart skills acquired to primary and second institutions. Eventually, every community will have individuals with knowledge in basic life support in a few years to come. Effort is being made to manufacture vaccines in the country for the sub-region and Africa. In the interim, government efforts to acquire vaccines has seen positive results. And at this juncture, let me share some data with you. Currently, there are 5 emergency use authorized vaccines approved by FDA. AstraZeneca, and I'll go along to give you proportionately the amounts that we receive. AstraZeneca, 53.6%. Sputnik, 0.3%. Johnson & Johnson, 14.6%. Moderna, 15.2%. And Pfizer, 16.2%. Total dose estimated to date
not to date, but as at 3rd November 2021, is 3.122.239 vaccines. Total proportion vaccinated by sex, males 47.9%, females 52.1%. We commend your parent organization for immense contribution towards the fight against COVID-19. Commitment of government and the ministry to support this agenda is in the right direction. Working together with corporate Ghana, we believe we could get sufficient air ambulances to make this laudable vision a reality. We will add our voice to Gaqhi'S call for support from traditional leaders, civil society organizations, religious bodies, corporate organizations, banking sector, district assemblies, as their corporate social responsibilities, since we are all beneficiaries of this noble initiative. It is also in the interest of the development partners to support these initiatives, since it will help in achieving sustainable development goals, universal health coverage, among others. Our people in diaspora with skills, aviation industry should be interested to support these noble ideas so that brain drain to diaspora in the past will become brain gain to our economy. Job creation will guarantee, and technical university will also have the opportunity for hands-on training, aeronautic and aviation technology. The proposal will be forwarded to the presidency for cabinet consideration. Government is committed to make healthcare accessible to all people living in the country. Long live Gaqhi, long live Minister of Health, long live Ghana, and thank you for your attention.
Thank you so much, Dr. Hafiz Adams Tahir. So that's a speech on behalf of the Minister for Health, Kweku Ajiman Menu. Do I have Dr. James Dua here? Dr. James Dua? Okay. All right, we proceed. So we've had a number of comments, we've had questions, and before we started this program, we're given the blessing to start first by God, and then our chairman gave us the all clear. My job was to steer the program. I want to see how well I did and whether there's anything else left. So I'm going to invite now our chairman for the occasion, a former Director General of the Ghana Health Service, Professor Bedu Akosa, to give us his concluding comments here.
Thank you, Mary. Good afternoon, ladies and gentlemen. I will stand on all existing protocols. It is Gaqhi'S turn, and I think that phraseology alone is good for this meeting. And why is it Gaqhi'S turn? If you look at Gaqhi, not only its health institutions, but the institutions that Gaqhi serves, it is huge. If Christian Health Association of Ghana does 40% of cases, health cases in this country, what do you think the combined force of Gaqhi will be doing? I don't think anybody has really assessed that. If you look at the resources that Gaqhi can command, I dare say that the health institutions are not the core businesses of the institutions that they represent. But at least, if these institutions are really in tune with what Gaqhi wants to do, I think the initiative, I would say, has begun. The main speaker's speech, I think, is a speech worthy of sitting down, a Gaqhi committee sitting down, and really exploring all the content of that speech. Because I believe that every bit of it is doable. And it's doable in present day context. Let's not build, I mean, it says that if you want to dream, dream big.
because it might just be achievable. So yes, let's dream big. But we know that without it, we will not be able to take the first steps. I think in this meeting, I don't know whether anybody, the Gaqhi executives, were taking some of the major issues that came up. You know, once upon a time, there was, Aziz, what was that? Teams from the center moving to the periphery. Within Gaqhi, you have a huge resource. Are you yourself able to begin to do that within Gaqhi? In other words, some of the specialties within Gaqhi can also move to underserved places. The issue of all the universities creating a system where, first aid and, all the university students almost becoming first responders is possible. Can we begin that? That is possible. So I think that for me, Gaqhi's turn is Gaqhi trying to let the population of Ghana know that, yes, they exist. Those who know they exist are those who come to your clinics and those who come to your facilities. But I think in its totality, Gaqhi is a powerful force that if you come together, you collaborate, even within Gaqhi. Unfortunately, most of our institutions are vertical, and there's virtually no horizontal communications whatsoever. But if we begin this, where there's a lot of horizontal collaboration within Gaqhi, the force of Gaqhi in the health care industry will be seriously recognized. Then we move to the air ambulance, which I think is a must. Already we've been told that it exists. And if it exists, let us begin to look at how it can be utilized and how it can be paid for. Those are secondary issues. The fact that it exists alone is good enough. But I want to go back to the main speaker's speech. If you listened to him very well, if you're carving this country into 15, we're just about 16 regions. So if you took all the regions together, I know that you used the longitudinal and latitudinal coordinates, and you could get 15, but with 16 regions. And I think the emphasis is that every regional capital should itself be self-sustaining. It's taking us too long. You build regional hospitals, you can't staff it. And yet, some of our facilities are overstaffed. And it is not anybody who can move people, it's the ministry. And the ministry by this time should have, made it a policy. You finish, you would move. At least, first of all, move to a regional hospital. And then from there, you move to a district hospital. That is how we started. But somehow, things have been allowed to, retard a little bit. It is important that every regional facility should be self-sustaining to an extent that they can manage most things that happen there. You limit referrals if you do that. I think one of the things that the Air Force Chief of Air Staff, is it? What he said was that if you move 4 evacuations, you can buy a CT scan. And yet, for the sake of CT scan, you move people, you evacuate, people to beyond regions. By now, CT scans, imaging has now become so crucial. CT scans, MRI, we cannot sit down and say that Ghana cannot afford 16 of these in every regional capital. I'll just share a little story with you. And this story probably would indicate how Ghanaians find it difficult when they are referred. As Director General, I arrived at Kwame Danso And as soon as I got to Kwamdan, so there was an emergency. Woman in pregnancy, antepartum hemorrhage, bleeding. No blood in Kwamdan. So, of course, they don't have a blood bank at that time. I don't know if they have now. So it was, can they get blood in Atebubu? Of course, those days were, you know, you ring, kring, kring, Atebubu. Atebubu, no blood. The next facility is Ejra and Atebubu. The hospitals are health centers, just named hospitals. The next one is Mampong, no blood. So this lady, for sake of getting blood, maybe now drones would have brought this lady blood, but then the patient is being referred to Konfanoche Teaching Hospital. And right in front of me, the woman said, leave me here. I will rather die here than go to Konfanoche Teaching Hospital. So sometimes we sit and talk about referrals, but we do not even know how the population think of us in our big facilities. They are faceless. And if you're coming to Konfanoche or to Kolebu, you have to come with relations. You don't have any place to stay. And they will never have a place to sleep. They will have to sleep in the open air in these hospitals. It is not good enough. And it all boils to the fact that health really is not this country's priority. But I would have thought that, if anything at all, the safety of the Ghanaian and the health of the Ghanaian should be top priorities in this country. Because if you don't safeguard the people, you know, once upon a time, the GMA had the wealth of the nation is the health of its people. If the people are not healthy, we certainly cannot deliver what this nation wants. I commend Gaqhi for this meeting. I think it is important, and I want to suggest to the President that form a committee, take the main speaker's speech, you know, pull it apart and begin to synthesize what is in it, because I believe it is doable. And if we start from there, in no time, we'll be doing bigger things. And then people will realize that indeed it is Gaqhi'S turn. I thank you all very much. Thank you.
Thank you so much, Professor Ajimambedu Akosa there. I think we can give him another round of applause. Thank you. All right, so lots of you have done so much. You've tried from wherever you are. You have other schedules. You still made time to come here. We need to thank you. And again, I don't have capacity. I'm just a moderator. I'm going to invite Dr. Gaqhi'S of the Graphic Communication Clinic at Adabraka to give us a vote of thanks.
Good afternoon, everyone. Mr. Chairman, distinguished gentlemen who grace the high table and who are in the audience, invited guests, past and present Gaqhi executives, fellow colleagues in the Gaqhi fraternity, sponsors, the press, and all herein gathered. I'm honored to be the one to thank you all for coming. When I look around, I see that no one here has free time, but everyone made time to come from far and near. We're grateful. When Na told me to do the vote of thanks, I said, so are you going to write it for me? He said, no. I said, so what do I say? Because usually when I go for programs and it's very long, I'm gone before it ends. But today has been a very enlightening experience. And we're grateful to all who contributed. We're grateful to all of you who stayed. If we listened well, the MC said that before this, he had never heard of Gaqhi. And I'm sure there are many like him. I was privileged to sit on a panel with final year medical students mock. And we asked them to list Gaqhi institutions. Everybody says 37 police hospital, and then you say, what next? And they look at you like, is there more? Have you heard of this? Yes, oh, but is it Gaqhi? Have you heard? Is it Gaqhi? And I think that we have heard enough to be able to stand up and stand together. And we want to thank you for committing to this conference, committing to the proceeds and committing to do more, as the chairman has said that we should sit down and digest the speeches that came. And we also pay glowing tribute to our founding fathers. We thank you, MC. We thank the past and present executives of Gaqhi. And most importantly, we want to thank the chairman and the panel members. They have shared a lot. In case you forgot, I want to mention a few things. We have heard Gaqhi's frontline response to the COVID-19 pandemic right from day one. We have heard about the proposed formation of intersectoral medical brigades. We have heard about the safety of Ghanaians being top priority and remaining so. And surprisingly, everything everyone said garnered around partnerships, the importance of partnerships, which coincidentally and interestingly is SDG 17. We want to thank everyone for the information we shared, the education and change in mindset. You know, typically when something happens in a household, in a home, even in the towns and cities, the first thing you do if there's an emergency is not to call the ambulance service. But if we work toward the mindset change, we will all get there. We want to thank everyone for the input. We are grateful. Every person here is very important to us. Everyone's input matters to us. We are grateful that you made the time to come. Thank you.
Thank you so much. I see that my confession in the morning is still being used against me. My confession that I didn't know much about Gaqhi. But I have an idea. You should perhaps withdraw your services like CHAG did at a point, the Christian Health Services. The media was everywhere. CHAG is on strike. CHAG has withdrawn. Maybe. That's if you have the capacity, go on strike. The media will talk about you. Then that's free publicity for you. But thank you so much. Thank you so much. We need a closing prayer now, and Dr. Evans will do that for us. He's the director of Cape Coast Hospital. Doc, please.
Thank you. Shall we be on our feet? We've been sitting for a while. Yes, we've all heard so many things, but it is written, many are the plans of men, but it's the counsel of the Lord that stands. It is also written that you can prepare the horse for battle, but victory belongs to the Lord. It is also written that guide your heart with all diligence, for out of it flows the issues of life. And life belongs to Christ. So shall we pray this wonderful afternoon. Father, we are grateful, thankful to you for all you continue to do with us. We are stewards, servants. May we be humble enough to execute the good plans you've placed into our hearts. For indeed, by no strength shall any man prevail. We pray that you be with us and harness all the resources we have. They are all from you, for there's nothing we have that we have brought. Everything we have comes from you. And it takes only also you to harness everything together, that at the end of the day, your name will be glorified. We thank you for this great meeting. You've gathered your own children, generals of the sector, and all. And together we've sat and we've fellowshipped to the good of your people, the people you've placed under our care. May all this be done to your glory. And we pray you also send us back to our various places. And may you strengthen us. And may the works of our hands be prospered continually. In the name of Jesus we pray. Shall we all say amen?
Thank you so much, Doc. Thank you. Let me just, you can please sit. Thank you. Yes. Let me just do a quick acknowledgement of Dr. Charlotte Osafo, who is with the Bank of Ghana Hospital, Bank Hospital. Doc, can you give us a wave? Yes, thank you so much. Thank you. Thank you for joining us. We need to go now. That's those of us who are foreigners to this meeting. But for the family members, there's going to be a family meeting afterwards. So if you're a member of Gaqhi, you're going to stay behind. But you do that after eating lunch. In the morning, I advise that if you don't eat, you will not be sensible in a meeting. So we'll go and have lunch down there. We'll take a group photograph. The foreigners will leave. The locals will stay to deliberate on a number of other issues, so that next year when we meet again for a conference, we would have learned lessons from today, and we'll make progress based on that. Having said that, I wish to thank all of you for being a wonderful audience. I'm grateful that you joined us again, and next year, if we invite you, we will be happy to see you, and we are happy that you'll be joining us. My name is Umaru Sanda Amadu. I thank you so much. Do have a pleasant afternoon. Let's go have lunch. Thank you.